Hi everyone. So today we are going to discuss about non-invasive ventilation. So you might be having so many doubts. So what do you mean by non-invasive ventilation? So whom should we put? Whom should we not put? What are the advantages? What are the disadvantages? What are the complications? How to use it? And what are the modes of NIV? Basically, you might be wondering, is HFNC is called NIV or is BiPAP is called NIV? So we are going to have a brief discussion on this topic. So let's go into that. So today's scope of discussion is how you're going to NIV work, what are the advantages and disadvantages, and how do we use that, what are the indications and contraindications, HFNC, CPAP and BiPAP. So basically what constitutes your NIV? Positive pressure ventilation delivered through a non-invasive interface rather than an invasive interface. Its benefits are actually rapidly being recognized. So what are the physiological basis of NIV? So basically what you're going to do is with your starts NIV, it will increase your VQ mismatch, it will get better, it will give effective mechanical ventilation where it will enhance your CO2 elimination, and it will improve your oxygenation lung inflation with adequate respiratory drive, and it will improve functional respiratory capacity in lung while just minimizing your work of breathing. So basically what you're going to do, so whenever you're going for ventilation, the issues will be, one, you have to improve your oxygenation, getting better on your ventilation population mismatch. The other is your low tidal volumes, right? So all three will be served here. Your effective mechanical ventilation and your CO2 elimination can be done, and it can improve your ventilation population mismatch, and it will improve your functional residual capacity in the lungs. So what are the advantages of NIV? So basically when you're intubating someone, there will be associated risk. You have to give sedation, you have to give paralysis, there will be risk of trauma, loss of teeth, aspiration and other things. And once a child is on ventilator, there will be risk of ventilator associated pneumonia. So you can reduce risk of VAP, you can avoid complications of intubation and mechanical ventilation. Once a child is on ventilator, there will be other complications such as VAP, or if the child is having any other issues with infection, shock and other things, so there will be high risk of mortality and morbidity. But here in this case it will reduce mortality and morbidity, and at the same time it will reduce your ICU and hospital stay, and it is done at low cost. So who is an ideal candidate? So now we know that these are the things, but what is ideal candidate? Whom should we put? Remember, you can start NIV only if your child is having intact airway protective mechanism. Then only your NIV is going to work. And you can't put on the verge of respiratory failure. If it is moderate to severe, but he should not be having respiratory failure. Then if the child is having good hemodynamics. So these are then hypoxemia only if your PF ratio is around less than 200. You can't start on a PF ratio less than 100. If the PF ratio is around 80, your effort requirement is 100%, and child is on the verge of respiratory failure, you can't start NIV in such patients. So where are we going to start? When the child is having good hemodynamic stability, intact airway protective mechanisms, and hypoxemia where your PF ratios are less than 200, moderate to severe respiratory distress, but on short of failure. So the right time is the sooner the better. So what are the clinical conditions where you see NIV? So acute hypoxemic failure, where the most better indication is the neuromuscular diseases or cardiogenic pulmonary edema. Sometimes where you have to facilitate your early extubation, we use that, and in obstructive airway diseases. So these are the conditions where we use it mainly in early extubations. So basically you want to extubate the child but still requiring some positive pressure ventilation. The best method is putting the child on NIV. So if the child is having CCF, having pulmonary edema, the best method is NIV. So what are the NIV interfaces? One is oronasal, nasal and pillows, or you can go for total phase. The last one is helmet. So now actually we are moving more towards oronasal. So each depends on the comfort levels of the patient. The advantages of nasal is it is less claustrophobic, easy to fit, but disadvantages is you should be able to do nose breathing, keeps mouth shut all the time, that is main issue. Face mask, it will permit your mouth breathing, it is suitable for moderately cooperative patient. Here you can use it around more than 10 years to 12 years age group, you can use more of a face mask. For kids, they will not allow face mask. So full face mask, avoid bridge on the nasal pressure, as you can see here. It increases the dead speed, but definitely not for claustrophobic child. Helmet, nowadays not much of using it. So monitoring during NIV. So you can divide it into clinical, lab, ventilatory parameters and other variables. So clinical, what you're going to see whenever you put the someone on NIV. As I said, if you put a full face mask, you should see for the comfort level whether the child is tolerating, your the respiratory rate is coming down, and your blood pressure is normal, and your saturation should get better. And you should have a close monitoring on the GCS. Coming to the lab parameters, usually how you are going to check that if the child is improved or not. Clinically, what you can see, as you can see, your rate is coming down, your sats are getting better, your heart rate is coming down, your blood pressure is getting better. But we need a proof laboratory also. So what you are going to do is, you can see get your PF ratio or your SF ratio, or you can do your ABG. Your ABG, you can check your PaO2 levels, and you can see your PaCO2 levels. As I said, NIV will help in generating good tidal volumes. CO2 removal will be done. Your respiratory stresses will come down. At the same time, your hypoxia will get better. Ventilation perfusion matching is get better. So in that way, your PF ratio and SF ratio gets better. So other ventilator parameters is main thing with NIV is its leak. There will be significant amount of leak, and there will be patient ventilator asynchronous. So you have to be standing on the bedside carefully whenever you put someone on NIV. So other variabilities, you should check, make sure the NIV is adequacy, the seal is adequate, it's properly fitting. Usually most of the times we put the NIV, it will be child moves or child tries to pull it off, the seal is inadequate, it will cause significant leak, and all the gas will be swallowed into the stomach, causes significant gastric distension and worsening of the respiratory distress. So what are the signs of improvement on NIV? So as I said, your heart rate and respiratory rate should get better, there will be increase in the effort requirement, and your PF ratio should come down, your SF ratio should get better, and your gas should get better. So what are the disadvantages of NIV? Main thing, the disadvantage, it is difficulty in tolerating the interface of the mask. That is the main issue. And if you put a nasal this thing, they'll be having so much pressure on the nasal bridge, causing sores. That is second issue. If there is inadequate seal this thing, so it will cause significant gastric distension, and it will cause, because of the dry mucous membranes, and there will be thick secretions and aspiration of the gastric contents. These are the main issues whenever you put the child on non-invasive ventilation. So let's go to the child, where should we try NIV or should we go for intubation? So let's discuss. So 4 years old child with fever for 3 days, breathing difficulties in 2 days. Your pulse guidelines. So airway is open and clear. Breathing wise, definitely see significantly tachypneic, bilateral entry is present. There is nasal flaring, severe retractions. Saturation on HFNC, it is 90% with FiO2 of 90. Circulation wise, heart rate is 182. Peripheral pulses are good. Gas is PaO2s are 60, PaCO2s are 55. Temperature is around slightly febrile. He is drowsy. GCS is 12. Remember? So he is definitely tachypneic. X-ray, you can see significant bilateral infiltrates are there. So it's fitting into ARDS, pulmonary edema. So child started on NIV. 2 hours later, the child started desaturating. Plenty of secretions drooling out of the oral cavity. Now what went wrong here? How do you predict your NIV failure? So NIV failure, as I said, your SF ratio, PF ratio, respiratory should come down, your SAT should get better, and your sensorium should be normal. But how you are going to predict NIV failure here? What are we discussed are positive findings. The negative things are, if the NIV failure, there will be no improvement in saturation, there will be worsening sensorium, tachypnea will be worsening pH and PaCO2, unable to clear the secretions, inability to tolerate your interface. All 5 things. Remember, when you start NIV, he should be able to clear the oral secretions. If the child is having GCS of 8/15, you can't start the child on NIV because he is unable to clear oral secretion. There will be high risk of aspiration and other things. So modes of NIV, HFNC, CPAP, and BiPAP. So nowadays we are more using BiPAP. So we'll discuss on that. So is HFNC a form of NIV? Definitely yes. So what do you mean by HFNC? So HFNC, the maximum generated pressure is about 6 centimeters water during aspiration. It is determined by, basically you have to make sure the prong and nostril fit is proper. So it will be different sizes will be available starting from XS, S, M, L and XL. It will be various colors, purple, yellow, green and red. So you have to check the sizes. It will be in the Fisher Park company. You should look for the sizes and fit accordingly. You will get the This thing also diagram where you can check with the nostril size. Accordingly, you can select the color or size of the mask. And it will not provide any assisted support, or it will not provide any tidal volume. It can be considered as NIV. It will just provide your low level positive pressure. So role of HFNC in apneic ventilation, definitely yes. So when your child start on HFNC, not getting better, you decided to intubate the child. So in such scenario, it does not interfere with the intubation because it is a nasal prongs connected to the nose. It will prevent hypoxia. As I said, it will give 6 centimeters of water pressure. So it will maintain your functional residual capacity also. So HFNC delivery equipment, as I showed, these are the Fisher and Parker Airbo 2 cannulas. So different sizes, red, purple. So how to set up HFNC? So remember, HFNC usually starts with flow of 1 liter per kg to maximum you can go until 2 to 3 liters per kg per minute. So how you are going to determine that? So if example, if you take a 4 kg child, the maximum you can start is 4 liter. The maximum you can go is until 8 liter. So if you take a child around 10 kg child, you can go maximum until flow of 25 liters. So the maximum you can go flow is 50 liters. If it is more than 40 kg, the maximum flow you can go is around 50 liters. You can go for medium or large size. In that way, you can determine the flow. As I said, you can start with 1 liter per kg, maximum you can go until 2 liters. In some scenarios, you can go until maximum of 3 liters, but definitely not more than that. The maximum flow the HFNC can deliver is 50 liters. How does CPAP work? So your CPAP, now we discussed about HFNC till now. Your CPAP, basically the CPAP, it will give good alveolar recruitment. It will increase your functional residual capacity, opens your collapsed alveoli. It will give constant positive air pressure throughout the cycle. In HFNC, it only during the expiration, but in CPAP, it will provide constant. Basically, the CPAP meaning itself continuous positive airway pressure. So it will be providing constant airway pressure throughout the cycle. It will increase your functional residual capacity and opens your collapsed alveoli. And also it will reduces your LV transmitter pressure, increase the cardiac output. Basically, in cases of CCA and cardiogenic shock, before we go for intubation, you can try CPAP because it will reduce your LV pressure and it will increase your cardiac output. And it will contract your intrinsic PEEP in cases of obstructive lung disease. So remember, CPAP is nothing but continuous positive airway pressure, where it will give your alveolar recruitment, it will give constant airway pressure throughout the cycle, it will improve your oxygenation, and it will reduces your LV transmural pressure, and it will increase the cardiac output. So what is the mechanism of action of BiPAP? So basically in BiPAP, you will be setting two things. One is during inspiration, inspiratory positive airway pressure. During expiration, it is called as expiratory positive airway pressure, IPAP and EPAP. So remember, when you intubate someone, what the things you require? One is oxygenation, the other is carbon dioxide, right? So remember, IPAP is nothing but your PIP. So basically for your tidal volume and your carbon dioxide. EPAP is nothing but positive and expiratory pressure. IPAP is for PIP, EPAP is for PEP. Basically for collapsed alveoli, to maintain opening of the collapsed alveoli. In that way, your saturations are going to better. So this is for EPAP is for oxygenation, IPAP is for generating your tidal volume, good tidal volume, CO2 removal. So remember in that way. So IPAP is for breathe in, EPAP is for breathe out. So it will decrease the work of breathing, it will improve your oxygenation and ventilation. So what are the modes on the BiPAP? One is spontaneous mode, timed mode, ST mode. So basically, usually we will keep the child on spontaneous mode, where your inspiratory effort will trigger the device which will provide the IPAP. Definitely will cycle back to EPAP. Where you send the child home, sometimes usually in such scenarios we give ST mode. So this will devise the trigger to IPAP on the patient inspiratory effort, but there will be a backup rate in case of ST mode. That's why I said when you send the child to home who requiring continuous NIV ventilation, in such cases we can child the home on BiPAP with ST mode. Why? Because there will be a backup rate. It will ensure minimum number of breaths, and there will be a device which will triggering your IPAP depending upon the patient inspiratory effort. Timed mode is nothing but it is purely machine triggered. The set rate will determine your trigger. Spontaneous, as I said, inspiratory effort will trigger the device to provide your IPAP. What are the BiPAP settings? As I said, IPAP is nothing but tidal volume or PAP. So PAP gives your tidal volume. So same way it is titrated to achieve your adequate chest expansion. In that way your CO2 removal. EPAP, it is direct removal. As I said, it is nothing but positive and expiratory pressure, which will maintain open the collapsed alveoli. In that way your oxygenation is going to better. So in that way you usually start it around 8. You can go until 12 to 14 also in cases of EPAP. So what do you mean by rise time? So basically rise time is nothing but time taken to reach the preset pressure. What do you mean by exact rise time? Is usually it start to 1 to 5 milliseconds. So if it is airway resistance disease, you have to give rapid. So it will be start with 1 millisecond. Airway resistance disease such as case of asthma or any hyperreactive airway disease. But in cases of restrictive lung disease, where the pressure delivered will be very slow, so that the patient will have the time to accept that pressure, and it will deliberately cross the rise time, go slowly the IPAP, and the pressure will be delivered smoothly. So that is the reason you go for restricted lung disease very slow, which is 5 milliseconds. So ramp time is nothing but usually we put the child so many times on NIV, on in home, in or in this thing. So gradual increase in the pressure delivery. So you can't directly put the child on NIV and start with IPAP around 20 and EPAP around 10. Definitely the child is not going to tolerate. So if you give the time in a gradual increase in the pressure, there will be child tolerance level will be better. Child gets accustomed to it very easily. The pressures will rise very slowly. The ramp time will get slowly. So that is basically nothing but you have to gradual increase in the pressure delivery. In that way, the patient comfort will be better. The cycle is transition from inspiration to expiration. So HFNC, CPAP or BiPAP, which is better? So HFNC ease of use is definitely good. Patient tolerance is definitely good, but not much of a positive pressure, not much of a tidal volume generation. So the best part with that is in BiPAP. In BiPAP, there will be good amount of positive pressure, good amount of hypoxia reversal, right? And good amount of tidal volume generation by your IPAP. In CPAP, as I said, it is continuous positive airway pressure to be delivered throughout the cycle. So there will be good amount of positive pressure, good amount of hypoxia reversal, not much of a tidal volume generation. The good amount of tidal volume generation is by a BiPAP, where you will be giving one through IPAP, which is nothing but your positive inspiratory pressure to open up the airway. And your EPAP is nothing but for your saturation. So in that way, your hypoxia reversal is very good in cases of BiPAP. So any role of sedatives, usually we don't, as I said previously, keep on continuously saying it. The child airway should be maintained, GCS should be good, hemodynamic stability should be there whenever you start a child on NIV. So what is ideal sedative? Usually whenever you put the child on NIV, the child is not going to tolerate. Definitely yes, because you put the infant or a neonate on a CPAP, with that you need bubbling for maintaining that continuous or constant airway pressure. Child will be very restless and irritable. So you need a drug where your reflexes are conserved, your consciousness is just minimally affected, and it will maintain your adequate physical and verbal response. So there are no clear indications as such on the use of sedatives. Usually we go with Dexmed sedation, which is better option, where the child will be more comfortable, not much of risk of hypotension, and conscious is very minimally affected, and your reflexes are also usually conserved. So summary, the first step is to select your appropriate delivered modality, CPAP or NIV or HFNC. The patient interface must meet the requirements and maximize the tolerance. Factors that may improve the tolerance should be considered. Basically, the final thing is you should be able to select the appropriate modality, whether you want to go for HFNC, CPAP or BiPAP. If so, why? Then once you select the modality, you should look if the child is able to tolerate that interference. So you can't put a neonate on a BiPAP. Child is definitely not going to tolerate. Or you can't put a 10 years old child on a CPAP. So you should be able to select the patient interface must meet the requirements, and it be able to maximize your tolerance. And factors that may improve your tolerance should be considered, like such putting proper face mask, adequate seal, and other things. And you can start some low dose sedation, making the child comfortable, or in case of BiPAP, give a slow ramp time. In such scenarios where your tolerance can be improved, should be definitely considered. Thank you.